well-being, our happiness is achieved through being actively listening and being part of our community. Part of that might be being involved in, for example, becoming involved in the community. Alma's here as a councillor for this ward. It's a particularly intense and close-knit community. So it's great if as many people as possible can become active in that, can become helpers, can become part of the community in that way. Is there anything you want to ask, or any issues around becoming political, becoming active? I'm going to have to leave, as I said. Speak to Alma, she'll be able to help you, or get in touch, in our case, through the party. We so want as many diverse groups as possible to be involved, to help each other to move forward. Thank you.
Thank you very much once again. Can we give her a round of applause again, please? Without wasting much of our time, we'd like to invite our first speaker. Is going to be talking on an overview of TAWV secondary care mental health services and what you really need to know, because I'm not so sure of this, and I'm very sure he's ready to support us tonight. And he's going to also be talking about challenges BAME community are also facing in these mental health services. So it's no other person than Ben Smith, Locality Manager of Middlesbrough Adult Mental Health Services. Ben Smith.
Can people hear me without a microphone? Yeah. Hi everyone, my name is Ben Smith. I'm a locality manager within TSS Weir Valley NHS Trust. Have people heard of TUBE as an abbreviation? Some people have, some haven't. So when I was preparing this, I thought I wasn't sure how many people were aware of TUBE or of mental health, so I'm just going to give an overview of secondary mental health care services that we provide, and then some of the challenges how I see them for accessing our services from the communities. Okay, I'd like this to be kind of interactive, so if there's any questions, please just ask as we go on through the presentation rather than at the end. So if there's anything that you're not sure about or talking in abbreviations, please just stop us and ask a question. Okay. So as I say, I'm a locality manager, so I manage all of the secondary mental health care services in Middlesbrough. So that includes our community provision and also our inpatient provision at Rosebery Park. Yeah, so just get me on there. So I'll just pass. There was a slide just explaining the referral route into secondary mental health care, because I think sometimes that's the confusing thing in terms of how do I access secondary care. So that document will just work its way around. It hasn't gone there, unfortunately, but it just describes the pathway. So the first route into secondary mental health care in the TUBE is at the GP. So once you've seen your GP, they can then refer into our service. And that's either crisis service. So if the GP is concerned that someone's in an immediate crisis, we will see you within 4 hours. Or there's the access service, which is the routine service, I guess, our GPs refer in, and we'll see you within 28 days. So there's 2 entry routes, so it's emergency or non-emergency. So that just helps describe that. It's got the numbers on it, so I can send that back after the event. So the first service, access service, so as I say, that's where the GP will refer in plus 511. We'll see you within 28 days, so it's relatively quick, the national target's 9 weeks. Locally, our commissioning group have set the target at 28 days to 4 weeks, so it's quite a short time, if you like. We'll undertake a comprehensive mental state assessment and risk, so it only takes an hour and a half. So we'll meet you in Parkside, or we can come to GP settings and undertake that secondary care mental health assessment and access. And then we'll either signpost you to other organisations, or you'll come into one of our teams. I'll describe the teams later. The crisis service, go back one, sorry. After that, sorry. Yeah, that's it. So the crisis service is 24 hours a day, 7 days a week, so we're always available. The crisis service is always there. As I say, we'll respond within 4 hours, so it's up to 4 hours as the response time. Again, we offer the same assessment that we do in access, but our crisis clinicians will undertake the assessment, so it's a complete assessment of mental health. We can offer intensive home treatment, so if we're concerned about someone immediately, we'll offer that intensive home treatment rather than an inpatient admission to Rosebery Park, so we'll offer that to a number of people within Middlesbrough. And again, we'll signpost, so if we're not sure, we can signpost our agency.
What does home treatment mean?
So that's, so someone's, if we're worried about someone's mental health, but we don't think an admission to the hospital is necessary, we'll offer intensive treatment in their home. So a nurse will be, there offering interventions, etc., support that person. We'll come away and the person will have our numbers and may go back a couple of times a night or through the day. So it's that kind of service where we prevent an admission in hospital. So it's called intensive home treatment. So it's keeping people within their own home, so we'll go out to them.
And that be as soon as within that 4-hour time period.
So after the assessment, so in 4 hours, we will do the assessment, and that will tell us does this person require intensive treatment, do they require nothing, just some advice, referral back to the GP, or inpatient admission, or the intensive home treatment. So there's lots of options. So yeah, it'll be within 4 hours you'll have that assessment, and there'll be different options to go. We also have the crisis assessment suite, which is at Rosebery Park Hospital. So basically that's almost 24/7 kind of walk-in A&E for mental health, if you like. It's quite new, it's been there about 2 years, so the local commissioners have invested a lot of money in their service, which is great. If you think of physical health, there's a number of places people can go. Mental health, there's the crisis service, which is fab, but this is an actual facility where someone can just walk in at any time, 24 hours a day, 7 days a week. Sorry,
Just what your referral process is from the police and NASA and immigration, because a lot of people are feeling that they're let down at those venues, their requirement for that support.
Yeah, so although the usual referral to GP, you can't refer direct to access. It used to just be a GP, so if someone didn't have a GP, access to mental health facility, we've opened that up so that you can refer, pick up the phone, speak to us, and refer direct into access. And the same rules apply, so we'll take us through the referral, we'll see someone within 28 days. So the barrier shouldn't be there now.
In theory, what is your relationship with the police? If they're holding someone for 24 hours before they even go to immigration, they've got into your advice at law.
So that's where the crisis assessments come in. So rather than, so we used to have, obviously police used to hold people in the cells. Now we have the crisis assessment suite, which is a safe place of safety, which is a much better environment for that person to be in. So people in police cells, hopefully there's eradicated or happen really rare. There's that crisis assessment suite, which is a better environment for someone. So that's where the police will signpost to, or they bring people to us on the section of the police cells, for example. So the relationship is quite good.
Do you mean people who are detained before? So not detained one, for example, like... I know, that's not. So you mean people like maybe locked up by immigration or held in the police station, what's the vision for them support?
Oh, right, sorry.
We recently had a volunteer,
You sound like volunteers could have been charged.
who was detained for more than 24 hours and she had issues. I was the first support offered that process. She tell out immigration and the eventual release
know it has been raised. I'm not an expert in immigration, I'm not like about basic, but I know it has been raised before about outside agencies, where they like to turn on to be recorded, so I don't know how I can sort of like
But that is an issue.
Yeah. Acute liaison service, so that's the service that we have in our acute hospital. So if someone presents in South East Hospital, really, we have our workers there to pick up and address their mental health needs. So we're not really acute nurses trying to manage the mental health. We have a service that is in the hospital. Again, we'll undertake exactly the same assessments, so comprehensive assessment. We'll offer some short-term intervention. And again, we decide also at that point to different services. So that's in our South East Hospital, that service.
Just checking, is in AD then, there's on duty always, I don't know if we still have psychiatric nurses.
Yeah.
Sort of specialist nurses. So there's always someone there who actually might recognise something.
Yes, so someone present the A&E will refer to us, but we're in the building, so we're there. Yeah, 24/7. I just put a photo of our building, that's our community building in Parkside, it's on Park Road North. It's a new build, so that's where our community teams are based in Hillsborough. Within that building, we have the affective disorders team. So once someone's been seen and accessed, if that clinician thinks they require a secondary mental health care service, there's three options. There's the affective disorders team, which treats people with depression, bipolar personality disorder, eating disorders, people with dual diagnosis, so a substance issue and mental health issue. That's the team that we refer to. So I've done some work around this, and we've only got 17 patients out of our total caseload in the affective team who are from the Bay community. So quite low, I think, for minutes, but given our demographics, there's only 17 patients out of a total of 400. The second service up there is an early intervention and psychosis service, and that's if someone has a first episode of psychosis, that's the team that we will refer them to from access. And again, that's people experiencing psychotic episodes, hallucinations, and they have some delusions for the first time that that's happened to that person. And there's 18 people from the Bay community out of 111 patients in that team.
Just a question. Looking at that figure, 17 and 18, do you think it should be more than that, or is anything?
It should be more so. As a trust, we've identified that in our business plan side, that access to secondary mental health care is low. So it's in our business plan, and the things like this to try and help with that, to create events and values, provide some education. But yes, that's low, and I expect it to be higher than it should be. So hopefully things like this can help.
In terms of your primary early detection, that figure is quite reflective. So do you think there's a fall in communication between the early detection and then sort of more further support, or?
I don't think so. I think that's just how it's happened. I don't think there's any kind of. I mean, the AIPs are often younger people. Well, that's what we're doing. So that's as young as 14 up to 65 is the age range for that. So as younger people come through camps. So maybe there's more people identified within children's mental health within our AIP service. But yeah, you're right. That's probably where that's more effective in the society than us. I'm not sure. Each team get exactly the same level of training, so they'll all get the same pre-having training. So there's no AIP staff on receive more training. It's similar across. The last service is psychosis, and that's the people who it isn't their first episode, so they've got a dual psychosis, and that's the service that they would be referred to. 55 patients from 400, and no one said that's higher. So it does seem like the effective service with the eating disorders, depression, lower level mental health, if you like, is far lower once someone has psychosis. The figures are a bit higher, as you can see there.
Could I ask a question? In terms of the data then, have you got any geographical data to know where these figures relate to, which part of the town or area
Yeah.
people are coming from? I mean, I just don't interested in having
I haven't, I can get it.
No, no, I mean, you have
but I
that
haven't got
data
it to hand.
geographically, so we can study that and that would help get some indicators about where the gaps in provision are or where we need to look
Yeah,
ahead
yeah.
potentially.
Absolutely, that's a good suggestion. The next steps, yeah, we can look at the 55 where they reside.
Where they're coming from. Is there a group, is there an area, is there that
Yeah.
kind of thing?
So that's the core team. So we also in this organisation have special services. So we have a service looking at people with ADHD, which you may have heard of, attention deficit hyperactivity disorder. A team working with people with autism. We have a veteran service as well within the trust. A specialist eating disorder service, that's both the community service and inpatient. So we have hospital beds for people with eating disorders. We have a psychotherapy service across teams. And there's also a perinatal service. So those are the specialisms.
Could you just very superficially just tell us what we need?
Yeah. So ADHD is normally within young people, it's picked up within childhood, attention, deficit hyperactivity disorder, but for some adults, also it hasn't been kind of diagnosed within childhood, so we've got that service to support those with ADHD. So those patients will be within the effective team, but they'll get support from the specialist services, so we've got nurses who specialise in ADHD.
And if I had a child who was identified as having attention deficit hyperactivity disorder, what would I be looking at?
I'm not a clinician, sorry, I don't know what signs you would look at as a parent of.
Disorder in broad terms.
Like behavioural problems or
Yeah,
what
and
we
we
have
have schools,
school disruptive, that sort of thing.
Not able to focus on an activity.
Yeah, concentration spans or.
Normally it's people in childhood,
Yeah.
but adults often as you hit 18, fall off the service provision, try to support people better within adult services who have ADHD. It doesn't go away, it's a lifelong thing.
Oh, yeah.
Inpatient services, that's our photo of Rosemary Park Hospital. If people heard of the hospital, it's just as you go up Martin Road, just before you get to James Cook on the left. So that's where we have our inpatient beds. So we have 4 acute wards at Rosemary Park. We have 2 male wards and 2 female wards. So 64 beds in total. So that's for the whole of Teesside, so it's not just Middlesbrough. So 64 across the whole of Teesside. And we have an intensive care unit, if you may have heard of the psychiatric intensive care. There's 10 beds also on site. So we've got 5 mental health wards for adults at Rosemary Park. We also have a wards for forensic patients, but those are wards that are managed.
Can I just ask, is that sufficient beds? Or should there be more, do you think, in terms of the demand?
So as a trust, we're trying to reduce our bed base.
That's what we're about.
Improve community provisions so people are better supported there rather than requiring an inpatient bed. So we have reduced the beds, we closed the unit as part of the conferences. So the bed rooms have come down.
Is that a good thing or a bad thing? In terms of the need of people who should be in a bed somewhere being looked after with that level of care?
So there's always going to be a need, I think, for beds. But I think if I remember ones, I prefer to be supported in my home, in my community, rather than requiring a bed. But for those that need that bed, that inpatient stay, there's sufficient there. It is busy. The bed occupancy levels are high. Yeah, so that the length of stay average is about 20 to 25 days. Last month we had 80 admissions and about 64 discharges. So it's a very busy site. So as soon as someone's discharged, there's an admission. But we try and just have that period of assessment and treatment. So someone will come in, we'll try and understand what their needs are, offer medication or psychology support, and then discharge someone back. Part of one of those teams that I mentioned. So we'll go back with often with support, but not always.
Just ask if there's, since you've had this policy of care in the community or whatever you call it, if there's any correlation between violent crime committed by those with mental care and the reduction in beds.
I don't think there's any work take an hour way out around that accommodation. To my knowledge, there's been any work.
There has been some high-profile cases where individuals weren't provided the support or released from care that committed serious crime.
It is always going to be people involved. It's just everybody that is here right now is like settling on a level of some way, shape or form, and that's the way the police is involved. We are picking up to a certain extent the psychology of the agencies. So, it's just the nature of that. The more people are coming through, they tend to have some kind of like a little background. Even on like the UK, so it's just, this is really that way to all the time. So, it makes them it's just. It is more care than everybody. It is more in the community. So much more in the community. You potentially have disorders and everyone sometimes. About violence, what I mean?
I would say as well, I do work as a nurse, I work back always less than weeks. Those years ago, when people were being, this issue of care in the community was raised, and the exact same issues around behaviour and management of mental ill health in the community was raised. There are relatively, I know they're very high profile when it happens, but in fact they're very rare, the kind of violent, it's almost like a cliche, crazy person goes out and murders people. It's very, very rare that such things occur. Sometimes people make other people feel uncomfortable or uneasy because of the behaviours, but something more dramatic than that is unusual, and our concerns have been very long-standing.
We're very kind of planned in terms of so there is a risk assessment. There's a very long time discharge.
We have got meetings as well. Discharge meetings where discuss with the consult, people discharge plans, the risk, and criminal history, and the support practice. Everyone who
There's always a follow-up as well, so you can see someone within 2 days since the discharge and make sure that they have a face-to-face with those. They're told 7 days, but we reduce that to 2 days, 2-day follow-up. So people go with crisis numbers, so it's obviously about discharge.
Can I just make a point or question, whichever way you want to look at it? There have been anecdotal reports that people from asylum seeker, refugee backgrounds, and some backgrounds do not necessarily reach the thresholds when they initially present, and it tends to be later on in the process where they present at crisis point, either the police, for instance, picking them up. And I'm just wanting to ask what's being done. So it's all right where the referral pathway seems to be straightforward, but we know with the communities we're talking about specifically today, it's not clear-cut. And whether it's something about language or culture on both sides, do you know what the trust is doing around that?
So I'll get on with that. Yeah, sorry, there's a slide about.
Sorry, I'm jumping.
All right. Thank you, see the slides. Here we are. Okay, so I've just given this some thought. So this is my kind of thoughts around the locality manager, why I think there's some barriers, and also what I think we can do to improve the situation. So the first one's around the recognition of mental health needs. So obviously, sometimes there's an unwillingness, I think, within all communities to accept or just by identify mental health problems. So I think that's key. If we can recognise those problems, talk to people earlier on, then you can get onto the correct pathway sooner. So you're not waiting until you hit the crisis. So we're recognising it by a GP or family member, and then we're following that pathway as soon as we can. Social networks, so social isolation in the community, so lack of friends or community groups, etc. I mean, that's also a factor. Sex differences, that's in terms of access to mental health services, we know that males don't access. It also goes to pull the data up for those 1,000 people on our caseloads, the majority will be female. So there's still an issue in terms of differences from male and female and the stigma, etc. Cultural identity. Sometimes I think perceived as mental health as socially unacceptable topic of discussion within a number of communities. So I think if we can address that and the stigma attached to mental health, more people will access services sooner. And the relationship between service user or the perceived relationship and the healthcare providers, so waiting times, I think there's sometimes a perception that there's long wait times for mental health. The government have put in targets a number of years ago which didn't used to be there, so there was a long wait, but now the targets are similar to other services. So like I say, we have 4 hours to see someone and we report that out weekly. So if we've breached on the 4 hours, we're held to account as to why we breached and what we're going to do about it. And also for the 28 days, so we have a big report out to management around if we've breached that or not, and reasons why we've breached. Service pressure could be one. Currently in Middlesbrough, probably moving into week 3. So if you're referred today, you'll be seen within that 3 and 4 week periods, 21 to 28 days. So in Middlesbrough, we're meeting that target. Language, I think, is an issue sometimes. That we do have interpretation services that we use, so that shouldn't be a barrier. So if English isn't your second language, there is interpreters available. So once the GP notifies of that in the referral, we'll ensure there's an interpreter available. We will obviously liaise with the person that's been referred to the service in terms of that they already have an interpreter that they work with, etc. So that shouldn't be a barrier either. Responsible needs, so I think there's sometimes a perception that we don't respond quickly to people's needs. So we're trying to address that, so our assessments are tailored to individual needs, so we respond to that in a timely manner. Cultural naivety, sometimes I think in our services, because there's low numbers coming through access and in the teams, there's sometimes some naivety about different cultures. So as a trust, we do have some training that we offer to everyone, to all nurses within our trust around BLA, etc. culture. That's currently e-learning. I think there's probably more to do in terms of training within the organisation to open that up to actually face-to-face. People who understand issues more, so that accept that there's some naivety in terms of cultural differences. And the key one, I think, is awareness of services. So how many people knew all of those services were in Middlesbrough? Probably not many other people would know that we have this broad range of services, and that it's as easy as one GP get referred in and you will be seen and have that full assessment, like say an hour and a half, sometimes 2 hours, is available to anyone residing in Middlesbrough.
I know the concept of Middlesbrough, but it's just like that they are really different.
Sorry, yeah.
Redmond, Stockton, Martin, also being the equivalent in other areas in case you get people who are moving,
Yeah, it's exactly the same.
areas in different
Can I ask a question? How can you assess people? Like a mental health team, they force people, quite healthy people, away from their own home and put them to the mental health hospital without their free will. And then that person come out of mental hospital disabled. Is an English old lady or 60-something. I don't know. I will try to intervene. But they say, oh, you know the mental health act. So I really do know mental health act. You see, you could tell me what kind of law what kind of condition you can force normal people go to the mental hospital. Can you tell me? I think she's quite, now she let the mental health team go to the court, because it really didn't want. So I want to know, in this situation, how can she get protection before she gets into the mental hospital?
So the Mental Health Act law is there to safeguard the person. So if we say we phone crisis, we go out within 4 hours, that crisis clinician is really concerned about that person. They think they need that inpatient admission, so that the doctors, the wider team are looking at, while we're in the hospital. If that person say, I don't want to be admitted.
Yeah, she says she
So
doesn't
the Mental Health Act law means that we can admit their own safety. So there's a process of assessment with a social worker and 2 doctors. So it's quite a thorough assessment. So there's 2 psychiatrists and a social worker who can forcibly detain someone under the Mental Health Act. So it can for their safety and then it's the safety of the others as well.
Right. You know, I think the social worker, like in that case, social worker take her from Scotland to Scarborough. And then there's the mental health doctor, bring me. They say, how about her? I say she's quite normal. So the doctor said, yes, I believe she's quite normal. I go to release her. But another Asian doctor kept her there. So until she will be several months, she was frightened, and then when she come back, she's disabled. Before, every day she's driving herself to the team, in the gym. You know. I feel frightened, you know, if somebody get me like that, because you know where to ask for help. And now but she's English, you know, compared some minority can be in the same situation. So this one, I feel frightened, you know, how can we talk to the social worker? You know, how can you just do this? She got her own house, she got a car.
Obviously, I don't know. It's related.
Yeah.
The decision to detain isn't to take life. So it's a decision that's made between different professionals with family members.
Because she has no family. Anyway, thank you. I just want to know a little bit more about the mental health. Because when I said, oh, she's quite normal, she gave me a piece of paper saying I've been her representative to help her to prove she's able to do self-reliance in her own home. But they still say mental health act. So
it's a really good thing that's on the probably the best gift of the mind. Have you heard of mind? Mind Health Charity.
Yeah.
They've got some easy read leaflets with everything I've taught about really. So what is the mental health act? What is the effective service? So that's a good resource.
I think she was a victim of the social workers' care. They say they took care about her, but actually not really. When she comes out, she was very good. So if you really care somebody, you go to make people. Thank you.
Does that cover your point, Rachel?
Yes.
Yeah. Okay. So this is the last slide, I think. So these are the things that I think we can do better to improve access for the community to secondary care. So raising awareness about mental health, we need to do collectively, we should try to reduce that stigma attached. When you think of physical health and mental health, just in terms of how you see the funding situation is one thing, but just how people perceive mental health. So you talk to someone about going into an operation for the leg, someone was going into hospital for a mental health admission, yes, wouldn't necessarily talk about it, but we want to try and break that kind of stigma. So I think if we can raise awareness, that will help. Improving awareness of our services. People are aware of what is available to them.
Just to add to what she was asking, I think with PALS, patient advice and liaison services.
Yes.
PALS,
yes, so that's a service that yourself or your friends can refer to if you're unhappy with.
I can give you the contact maybe later.
Oh, okay. You know, sometimes you will have a lot of life, every day busy. So it's very difficult to go to file in the courts, is it? Just to feel, wish the systems are better. Don't let the people have to go through all this trauma. Okay, thank you.
Yeah, there's a service called PALS Patient Advice and Liaison Services. I'll give you the phone number or email so we'll support you with any advice.
I also think what would be helpful is training and support to healthcare providers such as you in terms of how we deliver tailored and culturally sensitive care. So we talk about our training package. It would be good to get support in terms of what we deliver from groups like yourself, so you can inform our training package going forward. And also use of patient and public involvement groups. So I was in a meeting earlier with one of our public involvement reps. She's very keen to understand what we're doing as a CST's locality around there. So I'm going to involve her in our work to identify gaps in provision. So as you say, look at the demographics, where our locations are from, where the gaps are, what training is required. So that will be key in kind of the next steps for this. That's all. Is that all there?
Thank you very much. We really appreciate you for that. I think we've already asked most of the questions, so maybe at the end of the day, we'll still have a kind of general discussion, parallel session, if we still have time towards that. Thank you very much once again, Ben Smith. That will lead us to the next speaker, McIlvenna, Health Improvement Specialist. Yeah. Sorry, just further information for us to have a kind of documentation, because we have a YouTube channel. There are people that doesn't have time to come to this event. They always follow us and watch those events and they learn from it. So I will please enjoin us to kindly use to kindly use mic so that we'll be able to pick those discussion, and it's going to be a good audible for people to learn from it. And thank you very much once again, Ben Smith. We appreciate you for that well-structured and detailed information. Thank you so much. The next team that we're going to call, they are from Public Health Southeast. They'll be talking about NHS entitlements, charges, and exceptions. I would like to invite the both team. The person that's going to lead is Edward Kunonga. He's the Director of Public Health. If you don't mind, do you want to come over, please? Alongside Rachel McIlvenna, she's Health Improvement Specialist as well. Thank you for coming.
All right, great. Thank you. Good evening, everyone. Apologies, I got here a bit late. We had a council meeting which was running behind schedule, and then I had a few things to catch up straight after that. But it's great to be here to talk about mental health. So thanks for your presentation. I only caught the last bit of it. But I think it's very important that we support our communities to achieve good mental health. I've always said that mental health lies as the foundation for everything that we do, and without good mental health, we cannot go on and achieve and lead more fulfilling lives. So if we can't get mental health right for individuals, then basically we are ruling them out for the rest of their lives, because without good mental health, then they can't contribute to society and to the big ambitions that we have here in Middlesbrough. So great to have colleagues from the Mental Health Trust talking to us about the role of the services, but I'm sure he has already covered that mental health isn't about mental health care. We need to get the mental health care right, but actually mental health is much, much bigger than the care that people should receive. And we need to make sure that our care services are sensitive to the needs of the individuals and that they provide individuals with the support that they require, but actually true recovery happens within communities. And I think the broader mental health agenda is more than the services. We've got Rachel here to talk us through about some of the changes that are happening in terms of access to NHS services as a result of the Immigration Act, and some of the work that Rachel and a colleague in public health led across the region to look at what are the implications of these changes. And perhaps the challenge for our communities is how these changes could be misinterpreted and resulting in people not accessing the care that they are entitled to, and subsequently having an impact on a negative impact on their own health and well-being, both as individuals, as families, and denies the community of the important contribution that they could make. So I won't take too much of the time. I'll ask Rachel to take us through the presentation.
Thanks, Edward. Right, so I was just going to do a quick whistle stop of what the legislation is, the rules around who is entitled to NHS care. and what to do if you know someone who is entitled or who is exempt from those charges. Healthcare in the UK is quite complicated, and especially if you were not born in the UK, it's difficult to get your head around it. Even if you were born in the UK, it's still very complex. So before I got involved with this work, I had no idea, and I found it really confusing. But going through, I'm hoping that at the end of my talk, it's a bit clearer for people, and especially if you're working and supporting with people who are not sure about whether they can access healthcare, you are more aware, more knowledgeable about it. So in the UK, healthcare is tiered. You've got primary care and you've got secondary care. So primary care basically is accessing your GP practice, having a nurse consultation. If you go to a pharmacy, you can see a pharmacy and get a consultation with them. That is classed as primary care, and that is free for anyone. It does not matter what your residency status or immigration status is. Everyone should be able to access that without any cost. Now, there's a caveat there. You might be charged for prescriptions. So if you are not exempt from prescriptions, for instance, if you have a HC2 certificate or you are getting any benefits, you might be exempt for that. But if you are not exempt from any of those, you have to pay for that. Another thing that people might not be aware of is that if you're accessing things like dentists, appointments, or seeing opticians, you may have to pay for that. So again, regardless of your immigration status, most people can access most primary care services. So the government has had for several years laws to mean that people who wanted to access secondary care would be charged. They've not necessarily been implemented, but following the Immigration Act, the government tightened the rules. And then, change to the next slide. Last year, in October, 23rd of October, the government amended those rules further to restrict who could access healthcare in secondary care. And here's the difference. So, accessing secondary care, when I say secondary care, I mean hospitals, is based on your residency status. And so if you're ordinary resident, it's not about your citizenship. If you're ordinarily resident, you can access secondary care without a cost. But if you're not ordinarily resident, you're classed as an overseas visitor. And there are many groups of people that fall under that. So it's based on residency status, and it's free to anyone that is ordinary resident. I'll give you an example. So if, for instance, someone was born in the UK and went to live in North America for several years and comes back, they wouldn't normally be able to access secondary care without a fee because they are not classed as being ordinarily resident. They would have to stay for a period of time before they could access that free of charge. So there are some groups of migrants that are not ordinarily exempt, not ordinarily resident, but are exempt from charges. So a couple of them, for instance, refugees. So all refugees are entitled to free healthcare. And refugees could be those who have been granted asylum, who have humanitarian protection, temporary protection orders in place, and their dependents. It's free. So they can go into a hospital, they can have treatments, etc., without a cost. Asylum seekers are the next category of migrants who are not classed as ordinarily resident. Again, they can access free healthcare while the application is with the Home Office, or if they've been refused and they have an appeal in, they can access it. There's no cost to them. Then you have a third category, which you call refused asylum seekers. They are usually destitute. Some of them might be supported by the Home Office. Some of them might be supported by the local authority under different acts. They can access healthcare free. There's no cost. So that means that there will be some people who are not getting support from the Home Office under Section 95 or Section 4 or from the local authority. Those people do not have access to free NHS healthcare, secondary healthcare. Therefore, they would have to pay for their healthcare. There are other classes of migrants who are exempt. First of all, you have children who are looked after by the local authority. Those ones are exempt as well. Prisoners and those who are immigration detainees as well. Victims and suspected victims. So people will be aware, I think it was 2 weeks or 3 weeks ago, it was Modern Slavery Awareness Day. This is the new biggie in terms of what's happening. So anyone who is suspected to be a victim of modern slavery or human trafficking, or is known and the Home Office and the authorities have agreed that they are victims, they don't have to pay. They might not be classed as refugees, they might not be classed as asylum seekers, but they can access healthcare in hospital free of charge if they have their application in the referral mechanism. And if they have any dependents as well, and any children under 18, as long as they are lawfully present. We've talked a little bit about mental health as well, and I'll go into a bit more detail around that. Now, prior to the amendments and the legislation, if you did not have status, I'll use that phrase, and you had to access mental health support, that would be free. But that's changed now. So under the current rules, could you go back, please? Under the current rules, only people who have been sectioned under the Mental Health Capacity Act or are receiving compulsory treatment can access and do not have to pay. So if, for instance, a person is wanting to utilize community mental health, because it's not compulsory, because they've not been sectioned, and if they are not exempt, would have to pay. So you might have some people who are destitute, who are not entitled to any of the free healthcare, who will have to pay. So something worth thinking about. Now, there are other classes of people who are not asylum seekers, refugees, refused asylum seekers. They might be European Union citizens. They tend to have something called a HIHIC card, European Health Insurance Card. And because the government has got reciprocal agreements with them, they are not chargeable as well for that. If they are nationals of Switzerland who also are not part of the EU, they can access free healthcare in secondary care. Then you have another class of migrants. So these are people who have paid what is called the health surcharge. So for most people who have got different types of visas, student visas, I've forgotten the names now. There are other kinds of classes of visas. In the application, highly skilled, for instance, is one. In the application, they will have had to pay the health surcharge. Now, they can access most healthcare, as anyone who is ordinarily resident can. The only exception is that they can't access assisted conception. So if they were a couple and had infertility issues, that's not included again. Some other things, again, you'd need to pay for, like I've mentioned before, prescription, dental treatment, etc. What's that? Right, yeah. So that's based on, my understanding is that's based on if you're on low income. So people who might be asylum seekers or refugees will be classed as that. And then also people who are accessing various benefits like universal credit, income support, GSA, when all those were there. So it's based on how much income you're earning. But because asylum seekers and refugees tend to get that exemption because they're classed as low income until they start working, then they are able to access that, and then they can get free prescription, for instance. Is that? Yeah. Well, I think it's working with trying to find out information about the actual cost of anything within the NHS secondary care is very, very difficult. I've even had personal experiences. It's just a rough estimate. You might find that many of the people who are paying the health surcharge do not actually utilize it because they tend to be healthy. So it's just a rough estimate. I'm not sure what economics was done to come up with that figure, to be honest, but it's something that people need to pay. Yeah.
I think it's a very important point. The work that we have done is about reviewing government policy, and obviously you will know that we are officers and we kind of implement policy as it is directed to us. It doesn't mean that we agree with the policy, and I'm sure Rachel will talk about some of the findings when we did a survey around in terms of is this really going to bring in the resources that are consumerate with the level of work that goes in. I think there is a big fallacy around health tourism. Don't get me wrong, in other areas such as in London, health tourism is a big thing, but up here in the Northeast, it's not as big a thing. But I suppose, given that this is a meeting that's been facilitated from a political point of view, we perhaps are restricted as officers in terms of how much we can go into the politics behind the policy. But what we can flag with you is what we are seeing on the ground and the implications of that policy. And maybe that's up to the party to start looking at, so what does that mean in terms of challenging that policy or lobbying for those groups who are disproportionately being affected.
So what services are chargeable? So most treatments now, if you're not exempt, then you'd have to pay. The regulations have also extended to community health care. So any provision that is not necessarily within a hospital premise, but is provided by an NHS provider, is chargeable, except the person is exempt. So that's very confusing as well. Charities and social enterprises who have contracts by the NHS are now required by law to charge upfront for anyone who is not exempt. So Edward mentioned about health. We did a survey across all the trusts in the Northeast before the amendments to the rules in October to see how well all the trusts were implementing the previous charging regulations, and we found that the result was very patchy. It was very mixed. Only 2 trusts could tell us how much they had even recouped back from this process. But what this means is that some people are wrongly asked to pay when they are exempt from charging, and some people who are not exempt from charging are able to access. So again, there's inconsistency across the trust in terms of how this is implemented. And for us, it's a concern for the people that are the most vulnerable, who need access to healthcare. So, sorry, just 1 minute. Another thing to point out again, when we're talking about vulnerability, is around community services. So, any pregnant woman would most likely give birth within a hospital, but will see a community midwife for the period of her pregnancy. So while as before, that wouldn't have been classed, now that it's been extended to community settings, pregnant women who are not exempt, so think of a vulnerable, failed, refused asylum seeker woman who happens to be pregnant, is now going to be chargeable. So community midwifery, like I've mentioned before, community mental health, termination of pregnancy, district nursing, support groups, advocacy, those services are now chargeable. Exactly. Exactly. So we, in public health, but there are people within the country who are here who have now had to, for whatever reason, claim asylum, etc., or are unable to return back. So we've got to think about the people that are here. We have, sorry, I'll just say this. We have fed into the consultation the government around the impact, and we recently carried out a health impact assessment of these new changes as well, and I'm able to share with anyone who's interested what we saw as some of the real issues that will come as a result of that. Just think of maternity, for instance, and childhood mortality is one. So Apart from maternity, everything else is required, as I've got a slide on that, is required as upfront charging. So a person will be informed prior to their initial appointment. So if you were seeing a consultant, you got a referral by your GP, the hospital most likely will call you and tell you that, do you know that you may be chargeable and this is the amount? Do you want to continue with the appointment? So people would go in and then you'd have to pay before you actually solve that. In terms of maternity is the only one, for some reason, we would like it to be exempt totally, but it's the only one that is not classed as, just leave it on that slide, it's the only one that is not classed as upfront charging required. So anybody who is pregnant should not be prevented from seeing healthcare. You'll be presented with a bill. Most likely they'll tell you it's costing 3,500, etc. for the cost of the care for pregnancy. That's a standard delivery, but you shouldn't be prevented from seeing, because at any point during pregnancy, that's classed as urgent, necessary, and immediate. So therefore, a pregnant woman will not be prevented from seeing a midwife healthcare professional, but she may be charged if she's not exempt from that. So we've had a number of stories about people who have been scared about it and have not accessed healthcare, but they're still going to be charged. And we know, especially in pregnancy, if a woman is not getting that antenatal support, the risk of complications increase. Some things are not picked up. So what services are free? A few are free. A&E. So we don't have walk-in centers anymore, at least not in this area, but we've got urgent care centers, minor injury units, up till the point where a patient is admitted. So if a person had an accident, for instance, and got into A&E and they had to resuscitate them, give them blood, at that point, yes. But once the person becomes admitted, they are chargeable if they are not exempt. Family planning services are free, apart from termination of pregnancy. Diagnosis and treatment. So this is really important. Treatment of specified infectious diseases and STIs like HIV, etc. The diagnosis and treatment is free, again, but many people are not aware of that because many people think they'll be charged. So if people suspect they're not accessing, that's free. Palliative care services, so for people at the end of life, that's free. Services that are provided by the NHS 111 telephone helpline, that's free. Treatment for physical, mental condition caused by torture, by FGM, domestic violence, or sexual violence, that's free. But again, it has to be, you have to be able to show that that treatment is as a result of any of those conditions I've listed. Health visiting, school nursing, those ones are free. Public health moved into local authority in 2013. So we took on some of the prevention work that the NHS used to do. So initially, when the amendments and the rules came, we thought, oh, public health services that we offer as part of our NHS role, if you want to put it that way, would have to ask people and charge them up front. We got some clarification around that. So any public health service that we commission, so local authorities predominantly, commission that is classed as primary care, meaning that you could deliver within a community setting, that's classed as free. So your children get measured once or twice, I think, while they're in primary school. That's free. Any health visitor check for under 5s, that's free. Any adult health check assessments like healthy heart checks that might happen within a community setting or primary care setting, that's free. Access to sexual health services, which local authorities commission, that's free. Weight management, if it's provided by local authorities. So if you have someone that is morbidly obese, for instance, and requires specialist support within a hospital to manage a diet, they are going to be charged. So just bear that in mind. Substance misuse, smoking cessation, and anything that you could class that public health is delivering, which is great because then that means that the preventative work is not affected by people's residency status. Next slide, please. So what happens if a person is chargeable? So I've touched on that a little bit. So now a person has to pay upfront, and if you're not exempt, you have to pay before your treatment started. So if you think about some conditions that require early intervention, that can delay that. Trusts can decide how much they accept. So again, I can't say, our local trust will take the whole amount or something else. It will be, I think, on a case-by-case basis. The government mandated that each trust have an overseas manager of some kind. So some are managers, some are just officials that just work there, and they manage all the claims. They are the ones that tend to send the invoices or arrange for the invoices to be sent out. There's a caveat there, but that's not always implemented properly, meaning that it's only a clinician, a doctor, a nurse, whoever is in charge, that can decide. It shouldn't be a manager in a trust that decides that a treatment is urgent and necessary. So if a clinician decides that it's urgent and necessary, a person doesn't have to pay up front. But with different trusts, I cannot tell you what happens in one trust to the other. Another thing for people to be aware of is that if anyone has not paid, so you get the treatment, say for instance, and you've not made arrangements with the trust to pay or clear the bill, if it's over £500, the Home Office will be contacted within 2 months, and that could affect a person's applications going forward again. What my knowledge and understanding about this is that if you know of an individual who is in that position, if they are able to speak with the overseas manager or people in authority and negotiate that, even though it's not possible really, because you're talking about vast sums of money, say I'll pay £5, £10, then their details don't get sent. But if there's no agreement in place, that's sent to the Home Office, and that's going to affect their future applications. Again, like I said, maternity care is classed as immediately necessary and urgent treatment, and should never, ever be withheld from any woman, really, because she's unable to pay. And we do know that there are many women who they're never ever going to be able to pay, but they get a bill. And then we've been talking about mental health as well. What does that do? You're supposed to be excited about the birth of a child, and then you're thinking about bills, etc. If there are complications, you have to have an emergency cesarean. That just escalates the cost as well. So a couple of resources, and if anyone is really interested, all I've said today is found in this leaflet, and I've got several at the back, so please help yourselves to them. It just explains very briefly, because we knew it was really complicated for people to get their heads around what exactly are the charges, who's exempt, who can access free health care. Just to mention also that this is only for England and Wales. Because healthcare is devolved to Scotland and Northern Ireland, they have different arrangements. And in fact, in Scotland, as far as I'm aware, there are no restrictions or exemptions. So if a person moves countries, then this is not applicable. But within England and Wales, the laws are applicable. So any information you want around that is there. There are also lots of documents are available. There's the full guidance about how to implement the overseas visitors charges, and there's also some documents around those people who have got no recourse to public funds. So you're talking about people that are destitute asylum seekers, or maybe some who are visitors or overstayers. I don't think they'll be eligible to get an HC2. I might be wrong, but I don't think they'll be eligible because they've basically used up all their rights. So they are the ones that are exempt, because if they had the HC2, they would not be chargeable. Absolutely. Yeah. So I guess the thing is to try and get them to see primary care, to go and see a GP. Now, many GPs are not meant to refuse a person if they don't have an address. Actually, I know in practice that doesn't always happen, but that can be challenged. So as long as a person needs to see a GP, they really should be able to see a GP. The GP can use their address as a temporary address, and that access there is free. So for anybody like that, what you need to do is try and get them even temporarily registered with a GP, so that they can see a healthcare professional. But if they require referral, they'll have to be charged. So there are some GPs that within Southeast that are quite happy to do that. I know it doesn't work in practice all the time, but they can see. You don't need an address. You don't actually even need identification to register with the GP. Now, GP practices, some of them have internal policies, but that policy must be such that they ask everyone. So they must ask everybody. If you're asking for pieces of identification from a person who is a destitute asylum seeker, you must be asking it from the general white population as well. So there's a leaflet that we have. So if you have cases like that, I can make that available as well, where a GP practice must give a reason why they refuse to register someone. And you can only do that if your practice list is full or a person has done a particular thing that puts your staff at risk. But apart from that, you have no reason not to register someone. And some GP practices actually just allow people to use their practice address so that the person can come and the person will get treatment. So, but I'm happy to provide that information for anybody. I think the first question, I'm not sure if they actually do, because from our health our survey we did, it was very difficult for the trust to tell us how much they had recouped back. So in terms of the implementation of the rules, I'm not sure how effective they are anyway. But your second question, I think it's quite difficult because I don't know whether it's called the NHS spine. Now, it flags up in the system when they're registering. So if someone, for instance, has a recent NHS number, for instance, it flags up. So it's difficult to bypass that process. It's just built in within all the secondary care systems that they flag up. And what one overseas manager said to me is that they pick up, they have several criteria. They have new recent NHS numbers. So for instance, if you had an NHS number and the person was like 40 or 50, why have they just got a new NHS number? So they were either not born in the UK or just recently registered. But then it also picks up several things. So people who have asylum cases in somehow are fed into the system so they can pick up on that. But then they interrogate that further. So if I was a visitor and for some reason I needed to be referred to hospital, I might not have an NHS number, but I've come into hospital, I need to be seen. That picks it up as well. So the overseas manager now uses all this criteria, and I think it's a standardized criteria to now interrogate further to see what's happening there and if that person is exempt or would have to be charged for it. So I think in terms of the system is nigh on impossible at the moment to get around that. So what my suggestion would be If there are cases that can be seen by primary care, let them be seen by primary care. Let people be aware of that.
I think your second question really highlights some of the ethical dilemma that doctors have. Exactly. Exactly. Yeah. Yeah. So when you speak to our colleagues in hospitals who are clinicians, they will tell you that the reason why they went into medicine is to alleviate suffering and help people at the point of need. The NHS constitution talks about access to NHS services should be based on clinical need and not on the ability to pay. So there is a whole range of ethical dilemmas. If you are a clinician and you're faced with someone who you know that through your intervention you can relieve their symptoms, you are either left to make an immigration decision to turn them away or to treat them out of your compassion and then have your overseas manager saying to you, you shouldn't have treated them. So it presents lots of dilemmas. The other dilemma that it presents is it then potentially means that you say to an individual, well, you're not eligible because your needs are not classified as urgent. So basically go home, get worse, come in blue-lighted in an ambulance, and then you're urgent, and then we'll treat you. Now, what does that mean in terms of the dignity of the individual, in terms of outcomes, but also from an economic point of view? We know that the interventions that we deliver for people who are blue-lighted into hospital are a lot more expensive than what we deliver for people who walk into the hospital. So some of this is kind of built on a false economy, which says that actually by turning these people away, that will make a saving. Actually, if those people go away and they become worse, then they become eligible, and we then have to pay even more.
Any more questions?
Thank you very much. Can we give a round of applause for the Southeast team once again?